Also, language matters. So we know that pelvic floor disorders can affect people of many genders, and it's important to use gender-inclusive language, but for the purpose of clarity and brevity, today I'm going to use the term women or woman to refer to anyone that is suffering from pelvic floor disorders, regardless of what gender they identify with. So I want to share some patient perspectives, meaning these are comments that I hear very commonly in my office. I felt something when I was in the shower. I didn't know what it was, and I was scared. No one ever talks about it. My mom would never have talked about something like this. I am so embarrassed. I couldn't even talk about it with my family doctor. He is wonderful. He has taken care of my whole family, but I just couldn't tell him exactly what was wrong. I just said, please just send me to the pelvic floor clinic. What is it? So when I reflect on these very commonly heard comments in my office, I feel that there are themes of shame, fear of the unknown, a societal taboo. So what I hope by the end of today's talk we'll be able to achieve is that we'll be able to shed light on this topic that has been previously shrouded in secrecy. So we're going to talk about what is pelvic floor, what are disorders, what happens, and what can we do to help. On the right-hand side of the screen, I have a picture of a very vajazzled vulva. And this is just to highlight that there's a reason why people have felt very uncomfortable talking about it or bringing it up. And it's because there's, long history of a societal stigma to talk about it and bring it out in the open. And a lot of my colleagues this morning have already raised it as being the culprit of why women's health has been disserviced for so long. This was my 3-year-old deciding to vajazzle my anatomy notes. So why do we even care? We care because this will affect 1 in 3 women. So if you're sitting beside 2 other people, look beside you to your right, look beside you to your left, 1 of the 3 of you is going to be affected by a pelvic floor disorder. Very common. And you have an up to 20% lifetime risk in North America of undergoing a procedure for stress incontinence or prolapse. That number is even higher if you think about procedures that we use for overactive bladder or fecal incontinence. So the rate of requiring a procedure, some intervention of some sort, is high. So what is this mysterious pelvic floor? I like to think of the pelvic floor, an analogy is it's a hammock. So a lovely hammock that you can rest and support your weight on. If you think about the pelvic floor as the hammock, and then those palm trees, those nice sturdy trees as kind of your bones, and then the ropes there as the ligaments, it's a soft tissue support made of muscles, ligaments, connective tissue in your pelvis, and it's going to hold pelvic organs like the bladder, the bowel, the uterus, and the vagina. So if you take a side view of a woman's body, so if you slice me down the middle, look at me from the side, front to back, you can see there's the abdominal cavity, and then behind that is the bladder, the uterus and vagina, the rectum, and then behind is your tailbone or your sacrum. And this is what a normal pelvic floor should look like. You see that nice hammock of connective tissue and muscles that's supporting your organs up. What does the pelvic floor do? Well, it has a number of functions. I've already talked to you about support, continence, so control of your bladder and bowel, sexual pleasure, postural and core stability. And if the pelvic floor isn't doing its job, if it's been damaged, if it's been weakened, it's just not functioning the way it should, you can end up with things like pelvic organ prolapse, urinary incontinence, fecal incontinence, or pelvic floor tension. And as I was listening to this morning's conversations already, there's a lot of overlap with what you've heard. So, for example, Dr. Robert talked about chronic pelvic pain. Pelvic floor tension can be a big part of that. Risk factors. So why does that happen even? I'm going to start by saying that it's multifactorial typically. It's not just one thing. Childbearing, age, so increasing age, just like the rest of our body, parts of it don't work as well as we age. Pelvic floor is not going to be the only one that's vulnerable to that process. Increasing pressure. So increasing pressure can occur through chronic constipation. If you're sitting on the toilet and you're straining, I'm not talking about seconds, I'm talking about minutes and minutes. Or obesity, increased weight puts all that increased intra-abdominal pressure on your pelvic floor. Smoking can be a risk factor. So not just because smoking is bad and evil, but because smoking can affect your connective tissue quality. We know this just by walk down the street. You can tell who's a smoker and who's not a smoker looking at their skin. If those changes are happening on their face, it's happening everywhere else too. And poor connective tissue. So we've already kind of alluded to those processes already. Neurological conditions as well. I've been talking a lot about muscles and ligaments, but our whole body is controlled by nerves. If any of our nerves are not functioning well, they're not working as well, that affects our connective tissue down here and how our pelvic organs function as well. So we'll talk a little bit about pelvic organ prolapse because that is a big topic that people often think about when they hear pelvic floor. I have pictured here an egg. What does an egg have to do with pelvic organ prolapse? Well, a lot of patients will tell me, I feel like I'm sitting on an egg. I feel like there's a ball or an egg that's just right there. It's about to come out. I feel like a baby's crowning. It's a very graphic description, but it's pretty accurate for how a woman might feel. So childbirth, we've talked about those other risk factors. Childbirth is probably the biggest risk factor. And I like this picture because it kind of explains why and how. You have that lovely human fetus in there, it's gestating, it's growing, wonderful changes in pregnancy, but at some point pregnancy ends and it has to come out. If it comes out via the natural vaginal route, it has to come down through that muscular, stretchy connective tissue of the vagina, but on its way out, it's also having to come through the muscular, stretchy connective tissue of the pelvic floor. And sometimes it's not just a stretch, it's a tear, or it's injury, or it's a nerve injury, and so things are damaged because of that baby coming out. Or as one patient rather simplistically described it to me or explained it to me, she said, it's like squeezing a watermelon out through a hole the size of a lemon. And I said, yeah, you got it. So pelvic organ prolapse, what does it look like? I've described what it feels like to some women, but there are different kinds of pelvic organ prolapse that can occur. So you will hear different terms maybe when you see your doctor or you see one of us. But on the picture here I have, this is a normal pelvic floor, it's a side view. So same thing I've shown you before, you have the pubic bone in front. I'm glad I decided to stand for this talk, right? So I can point to my own body. The pubic bone in front, okay? Then behind that you have the urethra and the bladder. And then the vagina and the uterus, where the baby is when you're pregnant. You have the anus and the rectum, and then behind is the tailbone, and it's all being supported up by that nice pelvic floor, which has not been damaged. Well, if you have injury or weakness of the front part of the vagina and its connective tissue, then it allows the front part of the vagina, and behind that's the bladder, to start to push down, and you can have a bulge in the vagina. And that tissue, that feeling of something being right there it's not the bladder per se, it's the skin of the vagina, but behind the skin of the vagina is the bladder. And really it's just a hernia. So there's something to think about. You've heard of hernias in your abdominal hernias, right? So you have a nice connective tissue sheath that holds your guts on the inside. People can get hernias because there's a weakness in the fascia or the abdominal wall and you get this little bump coming out. That's just your guts, right? So then they have various devices where they push it back in, or they have surgeries to reinforce that layer. So a prolapse is just a hernia. It just happens to be in the vagina. So there's front wall or cystocele. Back wall is the rectocele, so the bowel can come down. And the uterus can also come down. Or if there's no uterus, the top of the vagina or a vault prolapse can happen. So these are types of prolapse. What about leaking? Have you ever walked down Shoppers lately or London Drugs? Beside all the menstrual products, there's a whole schwack of all sorts of incontinence products. So leaking, it's also known as urinary incontinence. Very fancy word, just means involuntary loss of urine. Leaking pee, there's lots of causes, lots of different types, but the two most common ones that we see in our clinic is overactive bladder and stress urinary incontinence. I want to highlight these two because it's the most common ones that are in the population, but they also are different, and it's important to understand that so people are not disappointed when they come for their consult. Overactive bladder is a nerve problem. So we talked before about how you need good tissue strength, but you also have to have normal nerve function. So when your nerves are not functioning well, then the bladder doesn't function well. So when there's a nerve problem, then overactive bladder is a little too hyper. It's a little too sensitive. And so treatments for overactive bladder are going to focus on the nerves. And then you have stress incontinence, which is the other more common one, and that's more of a support issue, a mechanical support issue under the urethra. So overactive bladder, this is a very common statement I will hear. I'll say, tell me one sentence about your symptoms. This is what women will tell me. I have to go all the time. I know where every bathroom is in the city of Calgary. Okay, some laughs, but I think it's a lot of truth in this. Symptoms, urgency. I gotta go, I can't hold it. Okay, I gotta go now. It's not like I go in 5 minutes or I go in 10 minutes. I gotta go now. Frequency, I'm going like all the time, literally all the time, every hour, on the hour, more than every hour. Nocturia, waking up more than once a night. You must be tired. I've had women coming telling me that they're waking up 4 or 5 times a night. No wonder. In urgent incontinence, sometimes that urgency is so strong that as people are rushing to the bathroom, they're holding and the pee is like dribbling out. That's an extremely distressing symptom for many women. So as I touched on briefly, the management of overactive bladder really is focused on the nerve part of the bladder. So thinking about what kinds of lifestyle changes can we make to reduce the irritants on our nerves and our bladder. Pelvic floor exercises can allow us to help provide sort of a negative feedback to tell our bladder, nope, now's not the time to go, we can wait. Correcting any vaginal hormone deficiencies. Dr. Shea already talked a little bit about this. And then if you've tried a lot of those conservative measures and you're still struggling, it's okay to ask for help further. And that comes in the form of oral medications, so a pill you take by mouth, and those medications are targeted at the nerves of your bladder to tell them to calm down. Remember, overactive, hyperbladder. So we want to calm those nerves down, which would allow you to have more time in between pees, allow your bladder to hold a little bit more and not feel so panicked. If medications don't work for you, we are fortunate to have other treatments available, and those come in the form of bladder Botox or sacral neuromodulation, both treatments that are focused on the nerves. So stress incontinence is the other one that we talked about. Stress incontinence doesn't mean that you're stressed, doesn't mean you need to take a chill pill. What it means is that when we stress our pelvic floor by adding increased pressure in the abdomen, the supports that normally prevent the leaking are being overcome and you have leaking in those high exertion, high pressure situations. So activities like running, jumping, lifting heavy weights, having a really good laugh, dancing. These are very common activities, we hope, in your day-to-day life. And so if you're not able to do those things because you're leaking in those specific situations, that is stress incontinence. So when you do any of those high impact activities, even just a chronic cough or a bad cold, that's another time when people notice, then it transmits this pressure to your pelvic floor. If your pelvic floor, including the support under the urethra, isn't as strong, then it overcomes that support and you get pee squirting out. Another good analogy that I have seen is you take a garden hose, it's got water running through it, you put it on your concrete garden garage floor, and if you step on it, no water comes out the end. You take that same garden hose, it's got water running through it, and you put it on a water bed. Remember water beds? You step on it, you can still get some pee leaking out or some water leaking out, right? So we used to have a bit of a concrete floor, now we've got a water bed. Briefly, I want to talk about obstetrical anal sphincter injury because this is also a topic that we don't talk about very much at all. We talked about the social stigma around prolapse and incontinence, urinary incontinence. Imagine how much stigma there is about having poop accidents. So having babies, again, is probably one of the bigger risk factors for this. And so you know that when you have the injury and the tears to your the vagina and the tissue under the urethra, it makes sense you're going to have injuries or tears to the anal sphincter, which is one of the muscles in the pelvic floor. And so if you don't have a good tissue support with actual anatomy, or if the nerve itself of the muscle isn't working properly, you're going to have accidents. And it's multifactorial, right? So you're not going to just be thinking about, well, can't you just fix it? Just sew it back. That'd be great if it worked for everyone. We know it doesn't. So we always focus on the least invasive options. Maybe we can do things to optimize the consistency of our stools. Maybe physical therapy and exercise can help optimize whatever muscle strength there is. So be aware that there are treatment options, a lot of which can be started by yourself in your own home. Let's talk a little bit about treatments for stress incontinence and prolapse, because I've already talked about overactive bladder. But the treatments really, again, if you're not getting the theme, it ranges anywhere from conservative, low risk, to surgery, which is not super high risk, but it's definitely more risk than conservative. So conservative options are are limited really to exercises, strengthening your pelvic floor, lifestyle changes, and pelvic floor physiotherapy, which we're so lucky to be able to have access to, although with caveats. You got to have funding for it. You got to be able to have benefits to pay for it if you don't have it as publicly funded program. Is used for prolapse, stress incontinence, and urge incontinence. We know that 50 to 60%, and this is well studied, report benefit with pelvic floor physical therapy. And that group-based is as good as individual therapy quite often. It is a non-surgical treatment option. And so you've heard lots about Kegels. Kegels, how do you do Kegels? I've heard some women tell me that they sit on the toilet and they just stop the flow of pee. And I'm like, okay, that makes sense to learn which muscle, but please don't keep doing it chronically, always 3 times a day. That is how you damage your pelvic floor. So I would say, think about, so everyone just sit quietly. Think about a little pea on your chair. You're sitting on a pea. Imagine that you're going to try and suck it up into your pelvic floor. Suck it up into your pelvis. Everyone just do that. See how long you can hold it for. That is a Kegel. Okay? 3 times a day, 10 reps, 10 seconds. This you can do in your own home, you can do in the car. There's also different forms of biofeedback, and biofeedback just means that you're using other mechanisms to help you know that you're doing the right contraction, because only half women can learn or are able to contract the pelvic floor properly with just me telling you this. So half of us are not doing it properly. Biofeedback can help give us the information that we're doing it right. I've had women go and do Kegels. So women go and do Kegels and pelvic floor physio, and then they come to my office because they've tried all of that. And so we'll say 50%, right? Because some people have improvement. And this, I hear this. Doc, I swear, after the baby, I tried so much physio. I did Kegels till the cows came home, and I have just never been able to get a good contraction. When I hear this, people are telling me this with shame, with a sense of failure. They feel like they let themselves and me down. Let me tell you, it is not your fault, okay? Because we have studies that have shown that after childbirth, there is injury to the muscles. I already showed you all the slides why that happens. So if you can look, there's like on the, I wish I had a pointer, but there's little black blobs off to the side. They've got an asterisk in the middle. That's a hematoma. It's like a blood clot. That one on the left-hand side is right after having a baby. If fast forward, that same woman, 3 months after, so really enough time that if you had a little injury, it should heal back together, right? What do you know? Those black blobs are persisting, which means that the muscle has not magically just grown together. So if your muscle has torn during delivery, why are you surprised that you can't contract when it didn't grow back together? I'm telling you this to make you realize it's not your fault. So if you've done Kegels and pelvic floor physio, still struggling, pessaries are an option. Pessaries are non-surgical option. They're silicone, they feel a bit rubbery. You put them in and take them out yourself. You can wash them with soap and water, and there's lots of options. I have pictures, many different options here, and that's because it's like shoes and feet, different size shapes and different styles for different feet, okay? So there's lots of options available. Pessaries might work, and it avoids surgery. That's probably the biggest pro. And the con is it might not work, but at least you can try. Sometimes associated with some discharge, and you have to be okay with managing it yourself, so putting it in and taking it out, or be dependent on someone else doing it for you. Surgery, I'm a surgeon, I love surgery, but I will always tell you it should be considered as a last option, at least once you've already learned about the conservative options and tried them. So I could talk for more hours about surgery, but I won't. I'm just going to tell you there's so many options that are available. It really depends on each individual patient and what your presenting issue is. You can be reassured that most of the surgeries we do are minimally invasive, so no big incisions on your tummy, and that's good because it's less pain, your recovery is easier, and generally done either as a day surgery or just one night in hospital. And there is kind of bread and butter surgery that we do. I call it nipping and tucking. It's vaginal native tissue surgery, which means it's done through the vagina. Native tissue meaning we're using your own tissue. Stitches that dissolve. The idea is that we're trying to create a scar tissue even after those stitches have dissolved, and that scar tissue is what's going to hold you lifelong. And many variations of surgeries that we can do. Sometimes we augment by adding different ligament supports. Sometimes we add a little bit of mesh. Sometimes, we inject something. It all depends. I don't have enough time to cover it all today, but hopefully this gives you an idea. So I realize that I'm now out of time. I have so much more to talk about, but I'll stop now. So hopefully there's questions that we can discuss more at the end. Thanks.